Let's turn to some other studies in less targeted populations. One was the so-called REVEL trial with a drug called Ramucirumab, an anti-angiogenic agent that showed what was publicized in press reports as a positive trial. Melissa, can you tell us a bit about that trial and your impressions of it?
Sure. Ramucirumab is a mouthful for this early in the morning, so I'm going to call it RAM because I think that's cute. There were 1,200 patients in this trial, and it was a second-line trial. So this is after your platinum chemotherapies. Patients got docetaxel and RAM or docetaxel alone. It was a big trial. There were about 625 patients in each arm. The progression-free survival difference when RAM was added to docetaxel was a month and a half, 4.5 months in the RAM plus docetaxel arm, and 3 months in patients who were treated with docetaxel alone. And there was an overall survival difference of a month and a half. Patients who got docetaxel and RAM had an overall survival of 10.5 months versus 9.1 months in patients treated with docetaxel. Now, there's some interesting things to note about that. They thought that the addition of RAM to docetaxel, the study investigators thought that the addition of RAM to docetaxel would improve the overall survival from 7.2 months to 9.2 months, or I guess 7.5 months to 9.2 months. So right away you see that this group of patients as a whole did better than we were expecting. But the difference between the delta, we say, the difference between the two groups was no more marked than expected. Now, this was a statistically significant result, and in the second line for patients who have progressed on platinum chemotherapy, there are very few trials that have been able to show this. And so this trial is remarkable in that regard. This is another example of where we should talk about what is meaningful.
I think it's an ongoing issue, this potential distinction between statistical significance and clinical significance. And there was a lot of debate about that, particularly now in an era where we are seeing drugs that are having overwhelming effects and 50+% response rates, prolonged progression-free survival, is moving the needle by 5 weeks at a time enough? And I see Nasser shaking his head. So what was your impression of this just in general, and are you swayed by the argument particularly for unselected populations or squamous patients? It's been so hard that this is still significant.
Well, I thought the presenter addressed this question effectively when Dr. Chris had challenged him in the discussion portion about shouldn't we do better? Is this really, this is a pretty low bar. Shouldn't we be shooting for another low bar, 4 months, which is not quite as bad as 6 weeks? And the discussant said, you know, we've spent a vast majority of our meeting talking about drugs for 15% of the patients. And now we're talking about a drug for the other 85%. And he also said we have to be realistic. Lung cancer is a complicated disease, and it's hard to make advances. And, these are modest, but let's be realistic. We've never been able to do any better than this. So I thought that was the most compelling argument in the case for it. I think that this drug, first, let's talk about the study. So 85% of the patients had not had any anti-angiogenic drug in the first-line setting. And that's okay, that's representative. I think angiogenesis inhibitors are used less in the first-line setting than maybe they were 3 or 4 years ago. But nevertheless, very few of these patients had previously been exposed to an anti-angiogenic. The study did reinforce what we've seen in just about every study of adding an anti-angiogenic to a chemotherapy drug or erlotinib, and that's that it increases the response rate. And that's probably the most important take-home message is the response rate was 23%, which is pretty good. This was a large study, so the confidence intervals are going to be narrower. What that means is that's a fairly believable number. If we reproduce the study over and over, which we won't, we would probably get a very similar number. So that is encouraging because traditionally the response rate in this setting is in single digits. But it comes at a cost. And it comes at a cost not only financially, but at a cost of toxicities as well. So I think in general, it's modest, it's disappointing, it's probably a real finding. Whether it becomes FDA approved or not is in the decision of other people. I think we have to think long and hard about the value of drugs like this with such a modest difference. In my personal practice, my patients are offered clinical trials. And so it's a no-brainer. If I have a clinical trial, I'm going to definitely recommend they consider that, and this would be a far second.
Dr. Bramer mentioned that one of the important pieces that is lacking, you alluded to it, is whether patients got an anti-angiogenic drug, i.e. Avastin, in the front line, and she would want to see what is the effect when patients get Avastin front line and then Ramucirumab second line. Is it as impactful, or is the response rate the same in that group of patients?